Hello, everyone, and welcome back to Ideas by Eye Doctors, a podcast brought to you by the Philippine Network of Young Ophthalmologists, together with the Philippine Academy of Ophthalmology. I'm JP, and we're excited to have you with us for another episode where we talk to inspiring leaders and innovators in the world of ophthalmology.
Hi everyone, I'm Angel Alcareza, and this podcast connects young ophthalmologists with the surgeons and mentors whose work has shaped the way we learn and practice today. And today's guest is someone whose innovations have helped many surgeons approach different cataract cases with confidence.
When cataract surgery becomes complicated, and when there is no capsular support, or when the intraocular lens just needs a different fixation strategy, many surgeons turn to techniques developed by our guest today. It's truly an honor for us, Dr. Sergio Canabrava, to have you with us in our podcast. And welcome to Ideas by Eye Doctors. Bom dia, Dr. Sergio Canabrava.
Hello,
Welcome, Dr.
JP.
Sergio.
I love your Portuguese. Bom dia. Perfect Portuguese, JP. Congratulations. Now you can come to Brazil because you talk good Portuguese.
Obrigado, Dr. Sergio.
Hello, Angelica. Hello.
Hi, Dr. Sergio. Thank you so much for joining us. It is a privilege to have you with us and with our listeners, many of whom are young ophthalmologists across the Philippines.
And folks, I'm here only because Angelica was a good fellow in my program, okay? If Angelica was a bad fellow, I would not be here, okay? Only because of this.
Thank you so much.
Oh, congratulations.
Let's go.
All right, so let's start at the beginning. Dr. Sergio, if you could share us a little about your journey during your early years of your career, what inspired you to pursue medicine?
Medicine, I come to a small city in my state, okay? And since the beginnings in this small city, to be a doctor is like inspiration. The city is about 6,000 inhabitants. People live there, and so since I'm young, I saw everybody talking about doctors and how doctors save life, and I think it was what inspired me in this. In my city, there is no industry or another inspired person, and so I think it was because this doctors save life in my small city, and I think it was the motivation.
I think that's a very common motivation to save lives and help people, right? But
Yeah.
particularly, what drew you to ophthalmology in medicine?
Ophthalmology is quickly different because during my medicine school, first I tried to be a clinical doctor, and after I think to be a surgical doctor. Okay, but since my medicine, I some people don't know, but I had a company that organized the biggest parties in Brazil. Yes, nobody knows
Events.
about it, but I really organized during my medicine school, because when I came to the capital to study medicine, my parents, there is no money to support me, so I start to organize parties, and so my parties become to be big and big and big, and so when I finish the resident, I looking for one specialty that I couldn't organize my company, and I had time. For example, when I go to clinical surgeon or orthopedics, I saw there is guardia, there is dirty. In weekends, there is working at night. And I thought, oh, I can do this kind of specialty, because if I do this kind of specialty, my company will close. And Angelica and JP, my company in that time
Yeah.
was really big. I organized about 10,000 medicine schools to travel to the beach every year.
Oh, wow.
Is a lot. 10,000 student medicine to travel with an airplane, hotel, and parties. Imagine how big company. Of course, in that time, I don't organize parties anymore. I sold this company, okay? And so
Mm-hmm.
is the real motivation to do to ophthalmology was this, to have time to organize my
Work-life
private
balance.
company.
Uh-huh.
Yes, this is
Mhm.
funny, but it's the real.
Wow, so you're a party guy.
No, the past, not now.
That's why you have many connections because you're into events.
Yes, but it was more than 15 years ago. I sold the company about in
Mm-hmm.
2014. About 12 years I sold the company. I started the company in 2003, but
Hmm.
I was with the company for 10 years and I sold the company.
That's so nice to hear. I didn't know that side of you.
Yes.
Okay, let's go to the next question. Dr. Sergio, during residency, many surgeons encounter both successes and difficult learning moments. For sure, everyone does. So, looking back, what were some challenges during your training that helped you shape your development as a surgeon?
One challenge that I had in my resident was when I was operating a patient with a single eye and a really dense cataract, okay? And that time I was in
Mm-hmm.
the third year of the residence, and I was really confident because my surgery was good. But in that day, I was without staff together with me. And so
Hmm.
this dance cataract don't become so good, and
Mm-hmm.
I was to convert it to scleral tunnel and remove it, and so it learned me a lot because it's a single eye. I think I was really confident, and I think it's happening with everybody. And sometimes the surgery teach you that when you are in a learning curve, you need to have a staff. And after this, I think it's like change. The patient was in a fascia, but I sent him a glass, and he
Mm-hmm.
had a vision. But my I was really good, with anxiety for about 15 days or 20 days till I'm be sure that the patient will don't be a blind single
Hmm.
eye.
Yes, yes.
And so it
Mm-hmm.
was a surgery in my third year of residence that really like shocked me, and I really was with a
Hmm.
CAT for a long time.
I'm also
Yes.
curious, Dr.
Mm-hmm.
Canabrava. Like after when, of course, you experience that complication, right? You get quite scared to do your next surgery. How did you overcome that fear coming into the operating room again after that event?
Uh, I mean, I was confident, okay? I was a confidence guy, confidence surgeon because,
Mm.
um, and so I back again, but I back with a staff together, and I back
Mm.
Mm-hmm.
with a easy case. And so I stop
Mm-hmm.
a challenge case at that moment, and like I back to the like the begins. Oh, let's go. And the important is really
Mm.
important to have when yeah, you are resident. It's really important to have a staff together with you
Mm-hmm.
to give your
Yeah.
support, because the first you need to think in the patient, not in you. You need to think in the patient. And when you are
Mm-hmm.
resident, and maybe when you finish the residence, you need to have a most experienced surgeon near to you to help
Mm.
you in difficult moments, difficult case.
True, that's true. The support system is really important anywhere, actually, not just in surgery.
Mm.
That's why we're also grateful for mentors, you know.
Speaking of mentors,
Oh.
Dr. Serio, is there anyone in your life that you consider a mentor that has influenced you the most in your career?
Yes, during my residence, I had 3 or 4 good mentors that I inspired in these surgeons. They are not so famous in Brazil or so famous in the world, but what I can say, there is really good staffs or there is really good preceptor that you can inspire during your residence, and I had about 3 or 4 that when I was in my first year, in the second year of residence, that I look, oh, I like to see like this guy because I like how this guy treats the patient, how this guy organize everything in the operate room, how this guy planning the surgery, how this guy sometimes don't operate the patient because it's really important, and how this surgeon speak with the patient, share time. And so these are important points. Angelica was with me for about 1 year, and how is for me is important to have a share time. I don't do a lot of surgeons per week because I need to have concentration. And I had about 3 or 4 surgeons in. They don't stay my hospital now because they like to retire, but they inspired me during the residence.
Yeah, I remember during fellowship that you really emphasize chair time. Like, whatever happens, it's important that you explain everything to the patient, even the complications, and most especially the complications.
Before, remember, Angelica, and you have a challenge case, it's important to talk with the family, with the patient before the surgery, and tell the patient, in my opinion, okay, folks, everything that can happen with the patient. You can be in a fascia, you can be sometimes phytisis bulbi because there is 3 or 4 surgeries in your eye. And so the patient and the family need to decide together with you if you go to operate this challenge case or not.
Thank you for that wisdom, Dr. Sergio.
So next, Dr. Sergio, is you are known worldwide for developing techniques for sclerofixation of intraocular lenses. So can you tell us about how you went about the idea of the famous Canabrava 4 flange technique?
Okay. Here in Brazil, I work in my private hospital and a public hospital too. In Brazil is a development country, is a poor country. In the public hospital, only to understand, the government pay $100 to the surgery, $100 to all the surgery, to pay the surgeon, the anesthesiologist, to pay the IOL, to pay the hospital, to pay everything. Imagine it, $100.
Wow.
So
Wow.
with $100, you do like miracles. You really don't have everything here. And so when I saw the Iamani technique, you had this kind of IOL in our hospital. And so I seek the idea, why not to cut the PDVF haptic and do a double flange? And the double flange start with it, with a PDVF. But one day, up in the third or the surgery number 4, which I start with a CTS, the capsular attention segment, not a IOL. I try to doing a really long axial length, and this doesn't work because the haptic is so small. And so there is no money in the hospitals, no money to Gore-Tex. And so I thought, okay, the PDVF in the Yaman technique is a plastic. The problem is a plastic, and the problem is $2, and there is a lot of problem in the hospital.
Cheaper.
Let's try to check if it's possible to do a flange in the problem, and the flange to work. And so let's go with the flange is firm, is don't break, and don't break. And so it's like this, the idea because the hospital there's no money, and because the PDVF in the Yaman technique is small. And so I know in the beginning it was difficult because nobody liked it to problem, and was difficult to show how the problem 5 in 60 is okay, because it's about 10 times more thicker than the 10-0. And so the history of the technique was like this. And we start with CTS, Angelica, and so no photo IOL scleral fixation. And after 4 closed loop, I try to piece in the IOL too. And after every day, I saw a surgeon doing a modification in my technique, and I really like how this technique in ProLens helps colleagues and patients around the world.
Yeah, really brilliant. It has helped so many patients everywhere for sure.
Yeah, I remember trying your technique in residency, but I had a problem inside the eye. The 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 flanges twisted.
Twisted.
Yeah.
Mm-hmm.
I think
Yes.
maybe it was a problem with how I went inside the eye.
No, it's now about 2 years ago. I did the modification, and now I inject the IOL first. And so, with the IOL inside the eye, above the iris, you paste the ProLens. With this modification, is avoid the cross, because the original technique was
If you do it
painting
outside, yeah.
the ProLens outside, and it's become
Mm.
like with you. It can happens with another colleagues and side cross the ProLens, and because this, I really try to solve the complication. And if you saw, there is many articles that I publish showing the complication and how to solve the complication. And I think because this, people like my technique and like to follow me, because I don't hide the complication. I show the complication and I show how to solve the complication. And this complication that you have, JP, inject the IOL inside the anterior chamber and so paste the ProLens. This is in the JCRO paper. There is my Instagram too. There is a how to do this modification.
Yeah, that's one thing I admire about you, Dr. Sergio. During fellowship, you really show us even the complications. And I think it's in the complications that we learn more, you know?
Yes, yes.
Yeah.
In the process of developing your technique, Dr. Sergio, I understand that sometimes you will still have some people that will put you down. How do you maintain your drive to continue to develop your technique despite even if a lot of people are criticizing you?
JP, I think it's because since my medicine school, I always receive,
This
yes,
is
some people say bad, because when
Mm.
something is new, you need to be prepared that some people, the jealous people, will say bad from you. And
Yes.
how I receive this bad word since the university, because imagine in the medicine school, I organized the biggest part in the Brazil. Imagine how many colleagues say bad things about me. You don't believe. Oh, this guy you don't complete the medicine school. This guy will be a party guy. This guy never. Yes, you don't believe. This guy never do a residence. And so,
you were judged.
yes, but I'm so that I'm in my mind that I was organizing party just to have money to support me in my city, because I'm sure in my mind that I not be a party guy for my dream to be a doctor, but my parents couldn't to support me. I become to a small city, and so I think how I receive a lot of bad words during all my medicine school. My mind was to prepare to it, and the words come here and go here, and I give in my focus like this.
Mhm.
Mm.
You focus on what's important.
Yes,
Mm.
don't listen or hear bad words. You believe in your dream, and you are sure that uh, everything okay. Go and focus.
Mhm.
Mm.
That's very important, mental preparation
Yes,
and all those things.
yes. But in my opinion, you'll never be mental preparation if you don't receive bad words. Okay. For example,
Mm.
with my kids, Angelica and JP, I have three kids, and
Mm.
sometimes I say bad words to my kids because I believe that they need to receive bad words too, because when you receive bad words in the school, they will be prepared. If you say for your kids only good words, you beautiful, you a sweet guy, when you go to the street in the school,
To
and
the
when they
real
receive
world.
the yes, in the world. And I believe in this kind of construction of mentality, as you told, Angelica.
That's true.
Mm-mm.
You also get to practice at home, so when you go out in the
So,
real world, you will be more equipped.
Mm. Right, right. So also to connect to that, you spoke earlier about preparing yourself before surgery, preparing the family before surgery. Can you take us through, Dr. Sergio, what do you usually say if the surgery does not go as planned? How do you take the family through that after mentally preparing them already, but still something happened?
yes, as you I tell you before, I always
Mm.
talk with the family before.
Mm.
So when you talk with the family before and show the family all the complications can happen, inclusive with percentage, for example, is better to talk with the family in the post-operative. If you don't tell nothing to the family before, if you hide the complication, you have a problem which you have the complication with the patient. If you discuss everything before, after to talk it will be easy because the family back home, the family have time to think, the family know there is the chance to have a complication, the family have the, you need to tell there is chance to you don't see with this eye. There is chance to be blind, especially in really challenge case. For example, sometimes came a patient to me that it was 2 or 3 operation in the eye, and I tell if I do the surgery number 4, you have a chance to have a chronic choroid detachment. You have a chance to have a phythiasis bulb. Do you want really to do the surgery? You need to tell everything before, okay, JP? If you don't tell before and you tell after, you have problem.
So it's just like the way you raise your children, you prepare them by letting them hear everything.
So another question here, Dr. Sergio, is a phakia without capsular support is a scenario many cataract surgeons face, and that's how you came about with your technique as well. So personally, how do you approach surgical planning when managing aphakic patients?
Okay, um, what is really important? Okay, number one, I don't like to be more than 1 hour and 30 minutes in the eye of the patient. Okay. For example, if you have a fake emulsification, a challenge case, there is a posterior pass plan, there is a posterior capsule rupture, and in my opinion, close this, do the posterior, the anterior vitrectomy, remove all the crystalline, and don't implant the IOL in this moment. Okay, wait for 30 days. Wait for the reduce the inflammation of the eye. The same, if you do, for example, a patient there is with a posterior pars plana vitrectomy, you need to do a posterior pars plana vitrectomy. It's better when you remove all the vitreous, check the periphery. It reduces the chance of retinal detachment of the eye. And you need to check the number of surgery that this patient was submitted. Okay? If you saw a patient with a eye anatomy is not preserved, there is this patient was submitted to a 3 or 4. It's better to don't do the IOL, the scleral fixation. Another important point is a single eye. Today is a patient, old patient, single eye. Sometimes I don't implant the scleral fixation. I prefer to this patient become with a phakia with a glass because included in my hands or in another specialist in scleral fixation hands, there is a chance to have a chronic choroid detachment, to have a problem. How I tell to the patient, GP and Angelica, I don't have problem with to do the technique, and I really don't have in this moment of my life. My challenge is the post-operative. I don't know if the eye will support a new surgery, if the eye you have a new retinal detachment, if the eye you have a chronic choroid detachment. And because this, for example, as I told you, single eye, sometimes there is the patient that is 203 previous surgery. I prefer to give this patient with aphakia and give only a glass, for example. It's like my quickly advice about the question.
So it's also not just about doing the surgery, doing it correctly, but also choosing when to do it and when not to do it.
Yes, yes.
It's a case-to-case basis.
Very nice. Okay.
But Dr. Sergio, in your country, would it be more expensive for the patient to have two surgeries or do it in one sitting? Because I believe the Philippines and Brazil somewhat have the same healthcare system, you know?
Yes, when you have two surgery is more expensive. But Angelica, I started with scleral fixation in 2012, so 14 years. And so what are you looking? What is better for the patient? When I became Angelica in scleral fixation 2012, nobody was talking about anterior vitrectomy. Surgeon do a scleral fixation without anterior vitrectomy.
That's
And
true.
so
Wow.
I become to see a lot of retinal detachment after 6 months, 4 months. And so surgeons start to talk about anterior vitrectomy, improved the results of complication. Because the problem was not the technique, but the long follow-up complication. And so
The post-
after surgeons become to discuss about posterior pars-plana vitrectomy. But I still some patient with complication, and I back to the information of the patient, and I look. Oh, this surgery was 2 hours and a half. Oh, this surgery was 2 hours. And so, what was my hypothesis? Long, lot of
Surgical
number of
time.
surgeries, long time inside the eye, more inflammation, choroid detachment, more inflammation, chance of retinal detachment. And so, because these are my current protocol, and I'm finishing a study, and I think I will publish soon to show best results in two surgeries.
You really have to know when to stop. It's also part of the decision making
Yes.
as a surgeon. Like,
Yes.
you can't really do everything in one sitting.
I'm just curious, Dr. Sergio. These days, people do just anterior vitrectomy. Would you say that's enough for most patients, or would it still be better for them to receive a complete pars plana vitrectomy before doing the Canabrava?
Today, I suggest a posterior pars-plana vitrectomy in all patients that I implant IOL. Sometimes, JP, there is a surprise. For example, when I exchange a IOL and I do anterior vitrectomy, I do the fourth flange, but 1 month this patient go to the retina surgeon and he complete the posterior pars-plana vitrectomy. So currently all my patients I suggest to do posterior pars-plana vitrectomy, check the periphery, do laser when was necessary, because when you move with vitreous, produce traction. And the problem is not in the immediately post-operative, JP, not 1 month, 2 months, but 6. And how I saw it, because the fourth flange is a new surgery. So my team need to follow this patient since the beginnings. And I become to see some patients with a retinal detachment after 2 years, after 3 years. And so, because this currently I suggest posterior pars plana in all my patients that I perform sclerofixation.
I would be very much excited to see the long-term data, Dr. Sergio, once you publish that. That's very exciting
Yeah.
sounding. Yeah. Speaking of the continued innovations, other than your Canabrava technique, there are other sclerofixation techniques out there, like the Yamane technique, and recently there's also the Carlevale IOLs, or the special IOLs designed for sclerofixation. Can you say something about your technique compared to these techniques in terms of what's the advantage of still doing your technique?
In my opinion, the most important in my technique is because in 4 points. And this is in 4 points is really avoid the chance of tilt. And if you have a tilt or a decentration in this, you can easily replace the problem. And the problem is the flash is really small. There's not produce a really problem in the sclera. When you go with a Gore-Tex, for example, is a really big knot. And so to remove the knot of the Gore-Tex sometimes produce a damage in the sclera. So the most important advantage in my technique is 4 points, and 4 points is more stable. It's avoids the tilt that you can see in the another techniques with 2 points. In my opinion, is the most important the most important advantage in the technique.
I agree.
Yeah, it's so stable. Actually, it's the Canabrava technique is very forgiving, especially in beginning surgeons. I think it's easier than the other techniques. So, next question, Dr. Sergio. When you anticipate a very complex cataract surgery case, how do you mentally prepare before entering the operating room? Like, do you have any particular framework that helps you stay composed when complications arise?
Angelica, it's become much time, okay? Uh, Today is like a pre-operative surgical planning, okay? In the beginnings, when I start, I'm write everything what I can do, and like the flow chart with the complication can happens. Today is really clear for me. I don't do the flow chart more. When I saw the patient, I have everything in my mind. It became so clear. Like I don't know. Sometime in movie see everything, but to come in this level, you need to do many years doing complex case. I have more than 2,000 really challenge case. And everybody saw my videos on internet or in Congress. A lot of challenge case, but in the beginning, you need my suggestion, right? Do a flow chart. Oh, this is a subluxation IOL. What I can happen? In the beginnings, when I start, it can be really unstable, and the crystalline can go to the nucleus. I need a retinal surgeon wait me. Oh no, I can start. It can be stable. So I you go to paste the CTR, use the macro hooks, and so. But during this phase can happen a posterior pars plana, posterior capsule rupture. What I can do if happen a posterior pars plana, a posterior capsule rupture in the middle of the fake emulsification. Okay, everything okay, but the posterior pars plana, the posterior capsule rupture becomes after to remove the nucleus. What I can do? So you need to plan every stage of complication happens, including suprachoroid hemorrhage. This can happen. What they can do? So, but in beginning, I wrote a lot of flow chart. I call it preoperative challenge, preoperative surgical plan for challenge case writing. Not more, but in the past,
And
yes.
and post-operatively, Dr. Sergio, you take notes of all that's happening during the cases, right? For
My team do it now, but the past, yes, I not and I record the videos in the part in our fellowship, some days I use the name, what I can do better here. Okay. Yes. It is
Yeah,
this,
yeah.
and I show it for the fellows what I can do better. And sometimes, of course, when I back to the surgery and I review the surgery, I can do better here. When you see your surgery, you always can improve it to do a decision making in the next surgery.
There's always a room for improvement.
Yes.
So, for the young listeners, what advice would you give them if they want to continue to develop or improve their surgery skills, Dr. Sergio?
The important thing to new, you talk about new technique or new skills?
New skills.
New skill
Learning.
for
Like if you're a beginning surgeon,
is always goes to the big meetings. Okay, is really important. Really watch videos. Okay, really participate in wet lab and dry labs, and really keep study. And what I tell to my Brazilian residents and fellow in person, don't do everything at the same time. When I start first with challenge case. For example, white cataract, dense cataract, small pupils. I change to challenge case after to be good. For example, I'm good in white cataract. Okay. I'm good in small people. Okay. I'm good now in for example, dense cataract. And young ophthalmologists, I don't know in your country, but in Brazil, they think that I build my experience in 1 year. No, I build my experience in 5, 7, 8 years, and I keep continuous. And it's impossible to try to do a good specialist in everything. Sometimes, JP and Angelica, I have a good surgeon, good residents that want to be a retinal surgeon, a cataract surgeon, and a challenge case. In my opinion, is impossible because my opinion, okay, Angelica, why I receive a lot of challenge case? Because colleagues know that I work only with challenge case. Of course, normal cataract too. But I don't do MIGS. I don't do, let me see, glaucoma surgery. Sergio, your hands, their expertise. If you want, you can. Yes, I'm really trusting my hands. If I want, I can't do retina surgery, glaucoma surgery, mix. But if I try to do everything, it's like a duck. You have this expression in Brazil. It's impossible to be good and to be study everything.
We have a question from just one of the listeners. When you recently modified your technique, Dr. Canabrava, last time that I learned it, it was you go directly inside the eye when you use the needle, right? Do you advocate for tunneling now, or is it still direct puncture?
No, I always do the tunnel. I always do the tunnel. I insert the IOL by the cartridge by incision 2.2 or 2.4 millimeter above the iris, but you need to keep the same. But now you paste the Prolen with the IOL inside the eye. It was the modification. In the original technique with a floor closed loop IOL, they paste the Prolen outside the eye. But for all modification in my techniques to fixate CTS, iris, subluxation IOL, or any Cioni ring, any modification that you saw that another surgeons using the flanged Prolen, I suggest to create a tunnel because I published in 2023 a paper with a follow-up for 5 years that show all the complication that I have was when the flanged was outside the eye. Okay? When the flanged stay outside the tunnel, outside the sclera. When the flanged stay inside the sclera or in surface of the sclera, no complication disflanged in the first follow-up that I finished in 2022 and I published 2023. Of course, now I keeping the follow-up and I will do a publication in 10 years.
Let's go to the next segment, Dr. Sergio. This is what we call the fast talk. So just choose just choose the first answer that comes to your mind. All right.
Okay.
So, okay, let's go. Horizontal chop or vertical chop?
Horizontal.
Temporal or superior incision?
Temporal. No, superior. Superior, but it's like 120.
All right. Phaco or M6?
Phaco.
Why?
Coffee or tea?
No coffee, no tea.
None. No caffeine.
No coffee, no tea, no alcohol, nothing. I don't like to. Only
Just water.
juicy water, sometimes Coke like this.
All
But
right.
I don't like coffee, don't like tea, and I don't like alcohol.
Even when you were
I never-
organizing your parties?
I never drink alcohol.
All right.
Yes, I think because of this, my party was a successful because I never
Wow.
drink in the parties, and I think was the secret.
Next, morning surgery or afternoon surgery?
I prefer afternoon surgery because the patient goes to home and is sleeping, and the next day is day better. Morning, I don't like because this.
Mm. How about mountains or beaches?
I like the both. I like the both.
Okay, but you do mountain biking, right?
Yes, mountain biking to sports and beach to relax it because this I like both.
All right. How about operating room or classroom?
Operate room, sure.
And what's the most important trait of a surgeon for you? Is it knowledge or skill?
I think the both too. I think the skills is important and knowledge is important. You need to keep
Right.
developing the both.
Dr. Sergio, thank you. Thank you so much for sharing your time and your
Thank you,
insights with
Sergio.
us. It has been such a wonderful and inspiring conversation. And two things. I would like you to give your final message for any of our listeners. And also, if you want to invite anyone to your advanced cataract fellowship as well.
Of course, my first message and take-home message is when you are a young ophthalmologist, you want to do everything at the same time. Don't do it, okay? Go step by step. You can be a really good specialist, but you need to develop your skills and you need to keep studying, but step by step. Nobody becomes a good surgeon in the one year, one month. You need to keep studying. About my course, it's a pleasure to receive. I try to select one person for each country to every year, and my next course will be this surgical make a decision course. JP, will be a really amazing course because there is no advanced cataract course this year because after three years I'm reorganizing it and I modified the advanced cataract course to surgical make a decision that I will try to teaching colleagues how to make a decision in the intraoperative in different scenarios. Thanks. Was a pleasure. It's a good conversation, a funny conversation. And I'm here.
Thank you,
If you
Dr.
need,
Sergio.
send me on Instagram any doubt.
Just one message away. Again, thank you, Dr. Sergio. It has been a pleasure for us. And to our listeners, thank you for tuning in. And don't forget our upcoming activity. We have esports this July.
Don't forget to follow and subscribe so that you never miss any of our future conversations. And to our listeners, thank you for joining us for another episode of Ideas by Eye Doctors, where we expand our vision one idea at a time. Until next time, thank you. Thank you, Dr. Sergio.